Are you a healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
What do concussion, pelvic pain, and the vagus nerve all have in common? This episode is going to challenge everything you thought you knew about recovery. I'm Dr. Jessica Schwartz, physical therapist, founder of the Concussion Corner Academy, and brain injury survivor. And today on the Concussion Corner Podcast, I'm joined by pelvic health powerhouse and yoga-informed clinician, Dr. Ann Duch, better known as @PT4Women, with her over 100,000 followers on Instagram. We're talking about the body's core canister, how trauma shows up in the nervous system, and why so many patients feel unsafe in their own skin after injury, whether it's from a car crash, childbirth, or chronic stress. If you've ever felt like your symptoms are being ignored or your healing is stuck, this conversation is for you. And we're so happy to be having Dr. Ann Collins Duch join us as being part of our Teach One, Serve Many community. Let's begin. Welcome, Dr. Duch. It's so great to have you on the Concussion Corner podcast.
I'm so happy to be here. Thank you so much for having me.
You know, you're an unusual guest for this podcast, I have to say. So I have a feeling that most people are not going to know who you are or maybe even why you're here. But for those that have listened to us in our last podcast, we just interviewed Dr. Jose Posas, who's a sport neurologist, and we just talked about intimacy and concussion. And I was like, you know what? Who better to bring on than a pelvic health physical therapist who's crushing it on social media and for your patients in your community? So I'd love for you to let the listeners know who may not know you. Can you share your journey into pelvic health physical therapy and how it intersected with your yoga practice and nervous system work? And take it away.
Yes. So thank you again for having me. I love the interdisciplinary work that you're doing. So I'm really happy to be included as a pelvic health specialist. My journey into pelvic health, I started as a lot of people do when they go into PT school. They think and I was a college athlete, they think they're going to be an orthopedic specialist, work sports medicine. That's what they're going to do. That's what I plan to do. Ended up working in a very fast-paced, high-volume sports medicine clinic, as many of us do right out of school. And what would happen was anytime someone came through the door who was pregnant, postpartum, or talked about anything in as the guys would say, the nether regions, anything below the belly button, they would end up on my schedule. And I had no more training than they had had in pelvic health. So it was kind of sink or swim. So I started doing a lot of my post-grad CEU courses in the pelvic health world because I just wanted to serve the folks that were ending up on my schedule. And at first I was kind of pushed into it, wasn't psyched about that. Once I got into it, I was like, I really love this. So really it started with a pregnancy and postpartum population, which moved into other pelvic health challenges, pain with intercourse, intimacy, urinary incontinence, things of that nature. That then moved me into the yoga space. I had rented a room in a yoga studio when I opened my practice, simply because it was cheaper than a medical building, to be truthful. And as I was kind of hanging around the yoga studio and I was starting to take some classes and I was speaking to the instructors, they were saying, your work that you do would complement this really well. I was invited to teach the anatomy portion of a yoga teacher training, and in kind of a bartering system, they said, and you can take the yoga teacher training for free. So I was like, well, this is a no-brainer because I love learning, right? So that kind of put me into the yoga space, and it's just started to make sense that the yoga space and a lot of the pelvic health work that I was doing really made sense coexisting, and kind of pulled more of that into my practice, which then led to the nervous system regulation work that I love to do.
Fantastic. And, I have so many relationships with pelvic health physical therapists, and people are like, well, you did an orthopedic residency and then you had your own brain injury. And then you kind of crossed over doing some work with APTA I was a media spokeswoman for 10 years. And people are like, why do you hang out with the pelvic PTs? And I can partially blame Tracy Sure, also known as the pelvic guru. But she introduced us, and really, it's just been one of the highlights of my professional career to kind of get to know you and see how you do your work and how you represent the profession on social media in such a positive way. And at the end of the day, we're all physical therapists at the end of the day. And in 2021, we had our 100th anniversary as physical therapists in this country as a profession. And we're all PTs at our baseline under that umbrella. And it's so interesting to see how full circle we've come in terms of, we treated traumatic brain injury literally in the trenches as in World War I as rehabilitative aids. And we've kind of talked about that mechanical relationship that some physical therapists have been kind of stuck in the last many decades.
Sure.
If not century, right? And then really how full circle we've come, where we're talking about vagus nerve conversations here on a concussion podcast with a pelvic health physical therapist and a concussion specialized orthopedic trained physical therapist, and how those areas intersect for our patients. And at the end of the day, I always advocate that patients are people and that we have all types of body parts, and we have a central nervous system, and we have genitals and everything that in between from a hormonal perspective. So I'm so happy to have you on to kind of really highlight and shift the language to maybe what some people on this podcast may have never heard. So I'm so stoked to have these conversations with you.
Me too. It makes me so happy. Yes, coming first full circle. I think when I graduated from PT school many decades ago, we were so mechanically focused, and I went through a great program, and there was all this talk about mechanics, and that was the primary thing in the very beginning of my career. And we were missing this whole other, we stay in our little silos, and if we don't learn about the nervous system and we don't learn about these other components, we're just missing this great opportunity to be better clinicians. So yes, I'm happy to be here.
Yeah, and I've spoken with Tracy Sure about this for decades at this point, over a decade. And essentially what we have so much in common is that often before patients come to see me in New York City, where I'm based, they've seen on average 6 to 7 healthcare providers before they get to me, and they've often been mismanaged. I said that during my well cared for recovery myself, when I did my recovery from my concussion that took 14 months to recover from after being hit by a car in 2013. And I still live with persistent symptom from that. And, I was speaking to Tracy for so long, which is how all of these pelvic relationships have kind of just flourished and opened up for me in terms of collegial friendships and colleagues. You guys were also experiencing a lot of the same. Can you maybe comment on what some of your patients experience potentially being mismanaged or not understood well by the healthcare community that is trying to serve them that just may not know?
Yeah, well, and let's be real clear. Pelvic health, it's been really exciting to watch it grow through the year. I've been doing this for 28 years. I was one of the first board certified. I think there were 60 of us back in mid 2000. As the pelvic health world has grown, I want to acknowledge we've done a great job of growing the specialty and making sure people know what we do, but so many people still have no idea what we do. So many physicians don't know what we do. So it's continuing to have these types of conversations so that our fellow colleagues know what we do, so that when someone ends up in care with them, they can say, let's talk about, in your world especially, let's talk about these things that no one else is talking about in the concussion world. It's not just about managing symptoms. It's about making sure that your life is full and complete, including intimacy, including being able to do the things that you love to do, and also doing them in a way that allows you to feel safe in doing them. I would say on average, I think that the stat that gets thrown around a lot is folks will wait up to 7 years with some sort of pelvic health condition before they even seek care, let alone find someone who listen to them about what might be best for them. And then certainly they will bounce around from clinician to clinician. And again, sometimes PTs aren't even in that conversation. They'll go to their OB-GYN, they'll go to an endocrinologist, they'll go to an orthopedic specialist. And then finally, someone will say, I don't know if you know about pelvic health, but I think they could be really helpful for you. And then you might bounce around to a couple different pelvic health clinicians until you find one that's a good fit for you. So it's unfortunately the same type of scenario.
Fantastic. Before we get into some terminology that I want to focus on, like AFAB and it's AFAB and AMAB. Is that correct? That's right. I want to just focus on, just generally hitting a piece of information for our listeners about essentially, let's talk about what pelvic physical therapy is and also what it is not, because unfortunately, I know this was in the news, a few years ago. But I think it's also important for folks to know that, hey, this is not just for genital, urinary incontinence. This is not just for painful sex. What are some areas that you treat? Who should be reaching out in general for pelvic health physical therapy, especially because you are so active and you work with so many athletes to keep people moving throughout all forms of life.
Yeah. Transitional care is what we're always looking at too. I'm working with folks as they're moving through puberty and starting to experience maybe some symptoms that they experience because of this new hormonal situation they're living in. Likewise, transitions through pregnancy and postpartum, and then perimenopause, menopause, gender affirming care when someone's going through a big transition. We want to make sure that we are filling any void that they have for general health. So the answer to your question, that was a little bit of but when we're talking about what do we treat painful conditions. We do treat urinary incontinence. And again, I think that used to be like, oh, if you're peeing your pants, you need to go see a pelvic PT, but we're so much more than that. When we get into, again, the intimacy piece, pain with intercourse, constipation, GI related issues, what am I missing? Gosh, pregnancy, postpartum, like I say, gender affirming care. We kind of cross a lot of different specialties. And I think we fill a lot of voids that folks don't really know we fill. And of course, sports medicine, making sure people are able to perform in whatever way they want to. So we talk about retired athletes, and I say that in air quotes. Once an athlete, always an athlete. If you are raising kids, you're an athlete. I promise you that. You want to be able to get out into that playground, go to the trampoline park, do the things that you want to do. So across all of these areas, and certainly perimenopause and menopause is having a moment right now, at least in my algorithm. I love to see it because I think before it was just like, oh, it's just something to get through. Good luck getting to the other side. Let us know how you are once you get there. And we're doing a much better job of addressing that these days. But again, I don't think pelvic PTs are brought into the conversation nearly enough. So I want to keep pushing for that.
And now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show. We have so many, talk about much more than just sports and concussion here at the podcast. We cover everything from intimate partner violence, and we talk about, pediatric to adult to geriatric concussions, so on and so forth, falls being the number one cause of concussion, traumatic brain injury, and so on and so forth. But then I just think about, where our crossover is, where if we're dealing with a Valsalva situation where someone's physiological autonomic system is not regulated secondary to a brain injury, how does that crossover if they are having some pelvic health issues as well? Either they had that premorbidly, pre-injury, or they developed it because they've stopped being feeling safe moving. Right.
Yeah.
And then they can't do what I get, especially from our kind of like football player looking fellas or bigger like CrossFit type humans that are doing things like, you know what, Jess, I can't work out. I'm like, well, what does that mean? First of all, like, what does that mean? They're like, well, I could like do the bike and stuff, but I can't like do a squat or I can't, do something heavy lifting. Like, so basically a type 2 is what they're giving me subjectively, a type 2 muscle movement. And again, that Valsalva increases intrathoracic pressure, increases intracranial pressure. And also we can talk about diaphragmatic and pelvic pressures as well. So I'd love if you can just comment on that so people can kind of see how this really does meld, especially when we may have an autonomic issue with the heart rate shooting up secondary to position and or intrathoracic or intracranial pressures. But how does that also affect you in your world where we're talking about pelvic pressures and diaphragmatic breathing?
Yeah, as soon as you talk about, you talk about Valsalva, like we're not even talking about just someone that wants to lift weights and get back to the thing that they love to do. Having a bowel movement. We have to feel safe being able to, and again, some PTs will say you should never bear down when you have a bowel movement. Sometimes it's necessary to bear down a bit when you're having a bowel movement. So being able to manage pressure, and we talk about the core canister a ton, the space between the diaphragm and the pelvic floor, what's happening in that space. And in the pelvic health world, that's our space, right? What is the diaphragm doing when we Valsalva? Could we come up with a breathwork technique where we can let out a little bit of an exhale in order to bear down effectively to have a bowel movement? And then can we take that into a lift, a push, a pull, a functional activity that someone wants to do, carry groceries up a 3-story walk up, while you're getting exhausted and getting to the top of those stairs? What's happening in this whole area? Are you holding your breath? Is your diaphragm able to actually move up and down with your breathing? Is your rib cage expanding? Do you have the mobility there to help you manage all of that pressure that's building up in that core canister? And then how does that affect the rest of you? Like you say, blood pressure, dysautonomia, POTS type, I always say POTS type symptoms. We want to start leaning into how can we manage those symptoms. And certainly the pelvic health, that space between the diaphragm and the pelvic floor becomes a really important part of that scenario.
I want to get back into the definitions in a second, but I'm going to pause just because we're in a good flow right here. So I want to just talk about the vagus nerve. And this is all, relating to what we're talking about with movement and function and pressures and things like that. The vagus nerve is a cranial nerve. It's cranial nerve 10, and it's the longest cranial nerve in the body. And it really traverses most of the body. So it's a key regulator, which we spoke about with Dr. Posas, of the parasympathetic nervous system, which is rest, digest, and recover. And when we think about concussion, we've been telling our patients to rest for decades. Again, in absence of evidence, we tell people to rest. We now know that that is a do harm situation. Beyond 72 hours, 48 to 72 hours, we tell people to do relative rest, okay? And then we see better outcomes after that. But they do have to have some period of rest because you can do harm if you do high intensity exercise after a brain injury. And we know that from tremendous work by like Dr. Giza at UCLA and Hovda, et cetera. But what it also connects to is recover and that feeling of safety that we're going to kind of keep in the theme between our two podcasts. And it really connects to brainstem to heart, lungs, the GI tract, which you mentioned, the diaphragm, even the voice box and pelvic organs, which again is why you're here. So we see that autonomic system dysregulation, which a lot of providers miss unless they're trained to look for it. And it's become increasingly popular with work from Dr. John Leddy talking about the Buffalo concussion treadmill test and looking at physiological aspects of concussion under the clinical profiles of concussion, which we've talked about many times on the podcast. Can you kind of talk about the importance of the vagus nerve in your work and how that may cross over with concussion patients who may have persistent recovery, who may not feel safe, who may have some had emotional trauma, if it was like from a car crash or intimate partner violence or anything like that, or have lost their jobs potentially, and also just that bi-directional pathway and why it's so important to be able to address this nerve?
Absolutely. This is my favorite thing to get into. We talk about the vagus nerve. You call it's the wonder. It's the big daddy of the vagus nerves. All of the vagus nerves are important. I just want to put that out there. They all live in the same neighborhood. So certainly how they are, they affect one another, just being adjacent to one another. So in the vagus world, I often talk about, I'm not saying the vagus nerve is the most important cranial nerve. It's up there. The other ones are of great importance, which is why we talk about eye mobility. And again, when I'm working with a pelvic health patient, I'm saying, we're going to do some eye movements. And they're looking at me like, what does this have to do with anything? I promise you, it has to do with all of it. But the vagus nerve you mentioned is bidirectional. 80% of what's happening in that vagus nerve is coming from the body telling the brain, giving the brain information. 20% is happening in the other direction. And I think for so long, especially for folks who haven't really been good at interoception, kind of feeling what's going on in their body. And this happens with a lot of high-level athletes. Not that I'm a high-level athlete, but we've been trained to just push through constantly. If we're feeling a certain way, you just grind and push through, which is where I think some of your concussion folks have a hard time knowing how to rest, like relative rest. What does that mean to a high-level athlete? Or what does that mean to someone who's got 5 kids that there's no relative rest for them. So the vagus nerve, bidirectional, lots of information coming from the body up to the brain. The brain has to figure out what it wants to do with that information and then help regulate from the top down. What I try to do with folks is, we know the vagus nerve has branches that go to those areas you just mentioned. A branch going to the jaw, to the throat space, to the heart. Lots of branches there. Through the diaphragm. Importantly, the vagus nerve it pierces through the diaphragm and then goes down to the viscera. Many of the branches going to the gut and talking with the enteric nervous system. So Making sure that the diaphragm is able to move up and down to help mobilize the vagus nerve can be one of the first things we do to try to get someone to be able to tone their vagus nerve to help them get into the parasympathetic nervous system. If someone is having symptoms that cause an increase in their heart rate, gut dysfunction, we can use the vagus nerve to try to help. We can use breathing and toning of the vagus nerve to try to help regulate some of those things. This interplay between getting into your body and actually feeling what's happening in your body, which can be very difficult for someone who's experienced a traumatic event and they've kind of dissociated from parts of the body. And this is where, certainly in the pelvic health world, we work with lots of people who've experienced traumatic events. And what I want to do is find global safe movement for them. And it might be something as seemingly simple as we're just going to stand and rock from side to side. We're going to find a sway. We're going to find some sort of rhythmic movement that feels good to you, that makes you feel safe. And then we go from there. So finding these global things, what type of breath work makes you feel better? What type of global movement makes you feel better? And then we can go from there. And I think the folks that have experienced a concussion can benefit from that type of approach sometimes versus going right into specific techniques.
And I think it all comes back to not being able to trust your body. And you see that a lot in the pelvic side, and we see that in the concussion side. Not able to go outside, cross the street in New York City, look left, look right without having visual trails. Again, you talked about incorporating eye work with your work in your pelvic health vagus nerve world. And, we talk about that. We have 2/3 of our brain's pathways are devoted to vision. 70% of our functional environments come through our eyeballs. So that's why we have a neuro-optometrist in our faculty for the academy side of things, because we do 3 weeks of the neuro-optometric exam and treatment for the non-neuro-optometrist, because it's so important to connect eyes. Because again, that visuovestibular connection is often not connected in healthcare and rehab. And so it's our job to make sure we promote that.
And I think, I think the important connection then is when you're having those trails and you're not feeling safe in your body will grip in different areas. And that, again, will send these signals from the body up to the brain that we're very unsafe now. The pelvic floor might be overactive. The abdominals are gripping. The jaw starts to grip. And then that just perpetuates this feeling of not feeling safe. And then it's this cycle, right? So I think it's important to note that.
Yeah, just thinking there, this is totally off for where I was planning to go with the conversation, but do you see any kind of, relationship to, or do you do any screening with your folks that may be coming in with constipation issues or bowel and bladder issues? Do you do any screening for childhood trauma or childhood connections?
Yes.
Because that actually may be something that we could bring into our questioning as well to see if, especially those with persistent symptoms.
Yeah, I think it gets, and this is in the public, it can get a little tricky because you want to make sure if we're screening for these things, we want to be able to work in conjunction with a mental health therapist. And I'm always very clear to say, I'm a physical therapist. We're going to talk about how things relate, how your physical body, we can never separate the emotional body from the physical body. We just can't. And for so long, I think when I was much more mechanically focused, I was like, nope, we don't talk about those things. That's not our lane. And now I'm much more like, oh, no, I ride adjacent to that lane. I make sure I always have folks that I've connected with that can help us parse through. Lots of times, in 28 years of doing this, I've had more than 2 handfuls of folks who reveal to me for the first time that they experienced some sort of sexual trauma or some sort of abuse that they've just never told anyone about. And part of that is we're in my space, they feel safe, we're starting to get into the body a bit, and these things will either just come up or they finally feel safe talking about them. So those are the folks I want to make sure we're working in conjunction with a mental health therapist that can help us unpack some of those things. So yes, there are lots of screening tools. I can share those with you and you can share them with your community, but making sure we know what we're doing with those screening tools, I think is really important.
Yeah, fantastic. And, as we head into the last minute of the podcast for part 1 of this, I just want to kind of connect something that we spoke about before the podcast to give listeners a little edge. Everyone likes to get a little peek into the behind the scenes. And, just thinking about what you said with the mechanical portion of this, that, we understand kind of like, hey, we can do something to the cervical spine. We just had Dr. Julia Trelevin, the world's leader in C-spine, on prior to you. We just had, sports neurologist on, and they can look at, hey, your headache or migraine is this. I can often prescribe a medication for this. And that we do support in the concussion community for migraine, because 94% of folks have headache or migraine, post-traumatic headache after a concussion. thinking of that globally safe movement and then really being able to trust our bodies. We've had that big push with therapeutic neuroscience education. You've lived through the 90s core excitement of the 90s where everything was core.
Yes.
And I think the vagus nerve is kind of the new hot topic now. So if you can give somebody who hasn't heard of this as a healthcare provider, whether they're in the rehab sector or on the physician side of things, OT, neuropsychology, et cetera, what would be some just key subjectives that you may hear that they may be hearing in their clinical side of things that may say, hey, you know what, this may be something that someone like yourself, like Dr. Duch, or someone that works with, vagus nerve specialization could help with?
Yeah, I think the first thing that comes to mind as you ask that question is unexplained gut dysfunction. So whether someone has been told they have IBS, and I believe IBS is a thing, I'm not saying it's not, but I believe that's become such an umbrella term for someone who's so dysregulated in their gut, they go from diarrhea to constipation. And certainly that can come from a lot of different pathologies, and we want to make sure we're not missing anything big. But when someone, if I have 8 patients a day, 6 of them are going to say, tell me about your bowels. And they'll say, I'm all over the place. Or I've been chronically constipated for years and I've tried all the things. I'm drinking all the water. I'm eating all the fiber. I'm doing all the things. And my gut is still a mess. We don't like that terminology, a mess. You're not a mess. We just need to work on some things. But that's the first thing that comes to mind. There's so much gut dysfunction that I think is coming from a dysregulated nervous system. And I think we're getting there. I think people are starting to recognize, but if you're a care provider and you're in with someone and you could just ask them about their gut, what's happening with your bowels, it will tell you a lot. Bowels and sleep are my 2 big questions. How are you sleeping? How's your gut?
Fantastic. All those things that make us human, right? At
Correct.
The end of the day,
yes.
We want to just be able to drive the car, move our bowels pretty independently
yes.
on a schedule,
yes. Sleep from time to time.
Sleep.
Yes.
And 8 hours of sleep is a beautiful thing. So, Dr. Duch, is there anything that you're doing right now in terms of courses or that you'd want to let people know where they can learn from you?
Yes, I have a virtual online course called What Happens in Vegas Doesn't Have to Stay in Vegas, nervous system regulation course. And I keep appearing on different podcasts talking about this, but my online course is probably the most accessible thing. I'm trying to get better in the YouTube world like yourself, but right now I'm mostly on Instagram. That's kind of where I put most of my little pearls. Yeah, so I hope if anybody's interested, please reach out. I love to talk about this stuff all day.
Fantastic. And where can people find you on Instagram?
I'm PT for Women on Instagram. I'm delving into TikTok a little bit. I'm not quite there yet, but you'll see me on Instagram.
Fantastic. Well, listen, when we come back for part 2 of this, we're going to talk about intimacy and concussion and some DEI and social determinant of health language, vernacular that can help clinicians all over the world, help speak with our patients across the aisle in a safe environment. So thank you so much for coming on. It's been an absolute pleasure, and I can't wait to see you for part 2.
Thank you.
If today's conversation opened up your eyes to deeper connections between brain injury and pelvic health and the nervous system, you're not alone. You can find Dr. Ann Duch on Instagram at PT for Women. Her course, What Happens in Vegas Doesn't Have to Stay in Vegas, is also available through her website and the link below in our show notes. And we'll be back in part 2 talking about intimacy, DEI, and the language that helps patients feel seen, heard, and safe in both pelvic health and concussion care. Don't forget to like, comment, and subscribe, and share this episode with a colleague who needs to hear it. Thank you so much for being a part of our Teach One, Serve Many community. Take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.